Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik NIkam. The feature presentation is on coronary calcium score, or CCS, and what do you do with that information. Let's first try to understand what is coronary calcium score, how is it measured, and how does it correlate to the incidence of cardiovascular events in the future. How do we modify the coronary calcium score, and how do they affect the outcomes in the long run. Before I go any further, I would like to tell you I have created a cardiology rotation manual consisting of 250 pages with the latest research, including all the ACCHA guideline references, and it will be a great resource for you, whether you're a student, a nurse, a doctor, a fellow, or a resident, or a primary care doctor in private practice. I'll tell you how you can get a copy of this at the end of this presentation. So let us continue with the feature presentation. If you are over 40 years, if you have history of hypertension or diabetes or history of smoking or high cholesterol or obesity, and you are concerned about the risk of having a heart disease, or you have a family history and you're concerned that you may be having a heart problem, your doctor may suggest you to get an electrocardiogram, and they may suggest you to do an exercise test. For various reasons, you may not be able to do an exercise test, and the other option is to do like a chemical stress test, including imaging like nuclear stress test, which is going to be quite expensive. One of the alternatives is, in addition to these tests, we can use coronary calcium score to determine the risk that is involved in terms of developing coronary artery disease. There are various modalities that are available to us, and coronary calcium score is an additional measure that will help us to assess the risk of having cardiovascular events in the future over a 10-year period. What is coronary calcium? What tests do you do? It is basically a CAT scan. You just go inside this donut, and within a few minutes it records your heart CT scan, and based on that we are going to determine if there is arteries in the heart that is calcified. Here's the calcium in the left anterior descending artery. You can follow my arrow here, and here is the left anterior descending artery shown in the diagram here, and this is how the heart sits in the chest. The CAT scan basically detects calcium because the shadow emitted by calcium is different from a shadow emitted by soft tissues. Using a complex formula, the computer calculates the amount of calcium in the heart, and the amount of calcium in the heart can range anywhere from 0 calcium in the here's a coronary arteries, as you can see, and this is without giving any contrast. When the CAT scan is done, no contrast is involved, no injections are needed. You just go inside the donut, they run the machine, and you get a chest CT, and from that we calculate calcium, presence of calcium, and calcium score. Here is a calcium score of 0 because in the arteries, in the region of the arteries, we see no evidence of calcium. Compared to that, here is a patient with a calcium score of 1200. That's pretty astronomically high. And you can see there's calcium in the aorta, there is calcium in the left main coronary artery and the branches, and the left anterior descending artery. And there may also be a stent here because it is so bright here, just like the bone cortex. So this is the evidence for coronary calcium, and we'll talk about what are the different levels of calcium we need to be concerned about. And this is how the CAT scan determines, and your doctor gets a report showing where the calcium is deposited and how much calcium is in the coronary arteries, and based on that we can calculate the 10-year risk of having cardiovascular events. And here are a few more examples where the calcium score is 0, and here you have a tiny speck of calcium in the coronary artery which is like 20, and here we have a lot more calcium in this area, and this is the diagram which we just saw a few minutes ago, which has 1200 angstrom unit it's called, and that's a pretty high number. Okay, and there's no calcium, and here is like the artery is lined up with calcium all along, and the branches also. This is the left anterior descending artery, and this is the diagonal branch. The left anterior descending artery is the one that comes in the front of the heart muscle, which is a major artery. Some of you might have heard of the term called the widowmaker artery, and this is the one which is supplying the large segment of the front of the heart muscle. Agatston score, that's what it is called, and when the score is 0, there is very low risk of developing heart disease over the next 10 years. Compare that with somebody who has a calcium score of 1 to 300, they are in the intermediate risk of developing heart disease. When the risk is low, that is like less than 5% chances of developing heart disease over the next 10 years. And when the risk is high, like when the calcium score is more than 300 or 400, which is deposited in the arteries, then the risk becomes high. So the risk can go up to 15 to 20% of developing heart disease and its complications over the next 10 years. When we combine that with other risk factors like hypertension, diabetes, obesity, smoking, family history, the problem becomes compounded, and I'm going to show you in the next several slides as to how the risk can become significantly more complex. So based upon the coronary calcium score, we can divide the patients into very low risk, intermediate risk, high risk, and very high risk. Of course, when you have a calcium score of more than 400, you fall into the high risk category. When the calcium score is 0, you fall into the low risk category. And between 0 and 100, we fall into the intermediate group, and between 100 and 400, you come into the high risk group. An important point I want to bring to your attention is as we get older, the amount of calcium in the arteries become more. And if you already have calcium on your coronary arteries, the amount of calcium increases with age. So if the calcium score is 0, the chances of having cardiovascular problem in a person 45 to 54 years is like anywhere from like 2% compared to a same person, a 75-year-old person having a calcium score of 0 who could have a risk of like 3 to 5%. On the other hand, if the calcium score is greater than 100, as the age progresses, and so do the risk of cardiovascular problems. As you can see, if a 75-year-old person has a calcium score of 100 or greater, the risk of cardiovascular events over the next 10 years, like mortality rates per 1,000 person years, is 35. So that's a significant risk. And going back to this chart, mortality rate based upon risk factors. I told you calcium score is just one of the risk identifiers, but we have other risk factors which can tell us if we are dealing with a significant risk of having heart problem, namely hypertension, diabetes, obesity, high cholesterol, and family history. So if someone has only no risk factors, then this is a low incidence of mortality. The calcium score is 0. On the other extreme, if someone has a calcium score of more than 100 and 2 or more risk factors, their risk goes up to like 14% per 1,000 person years. Calcium score is an important parameter which tells us about the risk of having adverse cardiovascular events in the next 10 years or so, so that we can address not only the risk factors but also modify our diet, exercise, weight control, all of which will help to reduce the cardiovascular events. The coronary calcium score has become so important in risk stratification of patients who are trying to find out if they have a heart problem and what is the risk of having cardiovascular events like heart attack or heart failure. The American Heart Association said coronary calcium score is an additional risk assessment modality that can be incorporated into daily practice so that we can have a better guidance as to how to predict the risk of cardiovascular events in the future. As I said, if it's low risk, it's less than like 3% compared to a person who has multiple risk factors and high calcium score. Their risk of having cardiovascular events could be like 15-20% or greater. The American Heart Association's 2020 study also showed that treating patients who have elevated levels of coronary calcium score with statins, along with risk factor modifications like diet, exercise, weight control, and all these things, will help to improve the patient's chances of having any adverse cardiovascular events, and it also decreases the rate at which there is further calcium deposition in the coronary arteries. And it is the same thing which said it reduces future cardiovascular events. I pose the question, can risk modification and statin treatment reduce the calcium score that is already there, that was detected by the CT scan? And multiple studies have shown that the risk factor modification and statin therapy decreases the rate at which the progression of calcium score happens in patients treated versus those who are not following the medical advice. If you strictly reduce your risk factors and if you're on statins, that will decrease the rate at which the deposition of calcium in the arteries occurs compared to those who don't follow the same prescriptions. More importantly, it also reduces the risk of having adverse cardiovascular events, which is a more important thing to be concerned about. So in other words, it does not remove the calcium that is already there in the arteries. It does not decrease the calcium score, but it decreases the rate at which the calcium would have been deposited if we didn't follow risk factor modification and if we are not on statins. So ladies and gentlemen, here is a chart showing that if someone has a cardiovascular risk of greater than 7.5 to 20%, which falls in the high intermediate category or high risk category, greater than 20% cardiovascular risk over the next 10 years, statin therapy is recommended for those patients. Whereas if the risk is between 5 and 7.5%, which is like in the low intermediate risk group, and we may consider statin, especially if they have other risk factors like hypertension, diabetes, or high cholesterol. So, ladies and gentlemen, if someone has a high calcium score like greater than 400, it should be of a major concern. You should be under the guidance of a specialist, like a cardiologist. In addition to modifying your risk factors, bringing down your blood pressure, controlling your blood sugar, cutting off smoking, getting your cholesterol under control, getting your weight under control, getting on a regular exercise program, adding statins will help to reduce the cardiovascular events to start with, which is the most important thing, and it decreases the rate at which the calcium deposition progresses. This is a quick synopsis of what is coronary calcium score and how it is done and how it is reported and what is its significance and how do we use the data in planning our treatment. Thank you so much for watching. I am Dr. Nik NIkam, and if you would like to get a copy of this cardiology rotation manual, which is designed for medical students, nurses, doctors, fellows, residents, or even primary care doctors in practice, you can send an email to Dr. Nik NIkam, that is drniknikam @gmail.com, and I'll be happy to send you a free copy of this PDF booklet. You have been listening to Triple N Media. I am Dr. Nik NIkam, a cardiologist. Thank you so much, and please do subscribe to our YouTube channel. We have more than 300 educational videos on heart disease and general medical problems. Please do watch them, and please do subscribe, and I will see you in the next presentation. Thank you so much.